I have to admit, it was a weird accident. I had put paver rocks on top of the grill to hold the old grill cover. So I took, I think, 7 or 8 paver rocks off. So here I am taking 1, 2, I don't know how many I had. And I started to pull the cover off, and there must have been 1 paver rock left that I didn't see, and it fell on my foot. So I stayed in the hospital for 10 days, and Andrea, who is involved with the hospital at home, came and approached me. And when I was ready to go home, people asked me, so what are you going to do when you go home? So I said, oh, I'm going to go to a hospital at home. They said, impossible. Nobody believed that it was going to be like that.
Hi, Barbara, how are you?
So the hospital at home program, it's, you know what, it's just amazing. We actually bring inpatients home and continue their inpatient care.
So, I'm going to get some vitals on you right now.
Really, the whole goal is create more capacity, meet community need for particularly vulnerable population, bringing the care to the home to expand hospital and health system capacity.
The hospital at home program really is designed to be able to try to keep patients who would typically be sick enough to be in the hospital at their home.
It's just nice being in your own surroundings, in your own bed, and what made it better is being at home.
I'm going to take it off and change it.
In this case, we are able to provide the same acute level of care in patients' home in their comfort. And the evidence suggests that, they're also having better outcomes.
And usually the nurses spend about an hour or so with the patient twice a day because you get 2 in-person visits. You're my only patient while I'm there because I'm really there just to take care of you.
I think it's a wonderful program, and I hope more patients will learn about it. And I feel very strongly that this is going to be the way of healthcare in the future.
We have a very, very, I would say, small but growing, but incredibly dedicated and tight crew of physicians, nurses, and paramedics who work very closely together. We are bringing the hospital to you.
My physical goals now are to regain my strength and my balance, and getting to walk my 4 or 5 miles a day.
Welcome to Becker's Hospital Review Digital Health and Telehealth Virtual Event and the featured session, Hybrid Care Innovation, the ROI of Bedside Virtual Care at Scale. On behalf of Becker's Healthcare, thank you so much for joining us today. I will first walk us through a few quick housekeeping details. You can submit any questions throughout today's session in the Q&A box on your dashboard. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's session to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am pleased to introduce the terrific speakers we have joining us today. Mike Brandofino, President and COO of Caregility, and David Smith, Associate Vice President of Virtual Medicine, UMass Memorial Health. Mike and David, thank you so much for joining us today. I will now turn the floor over to you.
Thank you, Mackenzie, and thank you, Beckers, for having us. This is always a great thing to do. That video is really, with one of our customers from UMass, is really a testament to how far healthcare has come in recent years. It also is a reminder of why we all do what we do in the healthcare space. It's great to see how innovation heals and brings that home, no pun intended, with home care. Their home program is a great example of how health systems are bringing resources to bear to improve outcomes, efficiency, and the experience for patients and clinicians alike. I'd like to welcome Dave Smith, Associate VP of Virtual Medicine at UMass Memorial Health System, who will share more about some of the hybrid care models he and his team are implementing to elevate the standard of care for their patients and staff. Dave, thanks for joining us today.
Thank you, Mike. It's great to be here today to share a little bit about how UMass Memorial embraces innovation really at all levels, but particularly around hybrid care. If I could just start with a brief intro of UMass and our mission. We're the largest healthcare system in central Massachusetts, an academic medical center, and the clinical partner of UMass Chan Medical School. We employ over 16,000 caregivers. And in our organization, everyone is considered a caregiver, regardless of title or function. Collectively, we serve over 1 million people across Central Mass. We're the region's only level 1 trauma center and level 3 NICU. So it's fair to say that we care for the sickest patients across our population. We are an Epic shop, and we are HIMSS Stage 7 certified in EMR adoption, which is the highest level that can be achieved. We've received CHIME's Most Wired Level 8 certification for the last 3 years in both ambulatory and acute care, and Epic Gold Stars Level 10 for the last 2 years running. And I don't highlight this to boast. It's really just indicative of how our physician-led leadership team truly embraces digital transformation. And that has afforded us the ability to be innovative and remain competitive. UMass has been delivering hybrid care in one form or another for the better part of 20 years. But beyond our EICU and telestroke programs, which were 2 of our flagship programs, we really struggled for years to move the needle. And that is until COVID hit. When that happened, we had to scale in a matter of days and weeks in order to address the needs of our patients who were suddenly forced into receiving their care virtually. So you might be able to see that model airplane behind me. I keep that airplane as a reminder of what our footprint was prior to the pandemic versus what we had to scale to, which was literally the equivalent of a full-size 232-foot Boeing 747. Now, obviously, we didn't maintain that, but the pandemic did 2 important things for us. It forced us to innovate, and it proved that hybrid care is just as effective as in-person care.
Yeah, that's definitely was a tipping point, I think, for all of our customers. And, the interesting thing about that is I think everybody focused on that, outpatient visit as being what virtual care was during the pandemic. But what's happened subsequently is all of these inpatient programs and the ability to do things like hospital in the home that were validated during that time frame. Now, I want to go back to that video because I thought it was really interesting. There was a mention in there of the use of EMS getting involved in the hospital in the home program. And that really seems like a great way to leverage additional resources. A lot of customers, a lot of healthcare systems are challenged with figuring out how to resource that hospital in the home. Could you expand on that a little bit?
Yeah, well, today we're facing a lot of challenges in healthcare delivery, as you know. Things like patient safety, capacity management, patient flow, staffing shortages, and they're all compounded by staff burnout and cost constraints. So we need to explore innovative hybrid care models like hospital at home, remote observation, and RPM in order to stay competitive. EMS has really been transformed from a shuttle service to a true mobile integrated health partner. And it's become a critical component of the hospital at home program. They really go hand in hand, and we're now equipping them with more technology so they can do more in the field. And now they have the ability to engage virtually with the hospital at home team from the home.
That's fantastic. I love seeing that. So with the expansion of all these programs, with hybrid care, can you talk a little bit about how you justify the cost? And have you seen results to date from an ROI perspective?
Oh, sure. ROI can be measured in a lot of different ways. It's not always tied to hard dollars or direct cost savings. For example, our EICU program is predominantly outcomes driven. We were focused on reduced mortality and length of stay as a means of improving patient care. Since its inception in 2006, we've seen patients go home sooner with fewer complications and a 27% reduction in mortality. And that means the cost of care is also reduced. For programs like telestroke and telepsych, the ROI is really about improving access. But also, community hospitals see the ROI because they don't have to hire and retain a full-time specialist. Instead, they buy professional services from a tertiary health system like UMass Memorial. Now, our remote video monitoring program, or RVM for short, it's probably the best example of a direct cost ROI because we have one PCA doing the work of 5 or 6 people in a conventional one-on-one observation. So that's a direct labor cost ROI. In fact, Mike, for every remote observation tech, we save $300,000 a year in direct labor costs.
Wow.
And it also helps meet staffing shortages. So that has been a very successful program with a huge ROI. And as you know, Mike, Caregility had a lot to do with its success. For our DAX Copilot rollout, and that's our Dragon ambient experience, the value proposition is 100% provider efficiency. And this is more than just a dictation solution. It actually spits out the visit summary as a structured note in clinical context in a matter of seconds. It can even filter out non-relevant information like talking about the Super Bowl halftime show. So it's helping to save providers countless hours of work. And for those who may be skeptical, our providers still review the note for accuracy before they sign it. But in terms of efficiency alone, would you rather write the book or just read it? Is kind of how we position it with our providers. Now, going back to hospital at home, this is great for patients because it allows them to receive the same hospital-based services in the comfort of their own home. But we really did it to free up bed capacity at our medical center and to prevent readmissions. In fact, in our first year of operation, we saved over 3,000 bed days at our busiest hospitals. And because of the vulnerable population it serves, the program also promotes health equity. And then the last example I'll cite here is around RPM and chronic disease management. Because people are living longer, they're dealing with more chronic illnesses coupled with a desire to age in place. The financial reimbursement for RPM isn't really there yet, but if you're an ACO or otherwise in a value-based care arrangement, then it definitely has financial incentives and upside with regard to total health ownership. So we have a mix of old and new, high and low acuity, inpatient and outpatient, but there's no question that hybrid care is the future of healthcare.
That's great. It's a great example, and we've been with you for a long time, and it's fantastic to see the progression and the adoption of programs, and the benefits that you're seeing from it. So it's gratifying to be part of that and to work with you. With all these new programs, clearly there are traditional KPIs that we need to look at, and I would also argue that there are hard dollar ROIs, as you described, and there are, I'm going to call soft dollar ROIs. And so that's going to require the health systems to really start figuring out, what KPIs are important, how to capture them. What are your thoughts on, are there new KPIs that you need to start capturing, and how do you go about trying to figure out, which ones to capture and report on?
Well, Mike, all of these measures are important to us. We don't necessarily associate them with dollar amounts, at least I don't. We're very focused on patient safety and quality outcomes, so that's where we see the value. We're also keenly committed to improving health equity, and that's where some of these programs are helping to improve access and outcomes. I will give you one interesting metric that we're starting to track. We have an advanced therapeutics program that screens our patient population for candidates for GLP-1 therapy, like Ozempic. As part of that, we've seen improvements in their A1C, but also fantastic weight loss. So our CEO decided he now wants to track and report the total pounds that we've lost under that program. So that's definitely a new KPI for us.
Sure. And that's definitely, we're watching what's going on in the space, and there's so many different programs. Behavioral health seems to be another big one that's starting to come up. And we're, customers are asking us for ways to help track, times in sessions and things like that, they're just trying to show the value of the program and the investments that they've made. So from a critical tipping point perspective, and we talked about that, at what point, and are we there? It almost sounds like we are. Is it table stakes to be, able to see and hear in every room? I think that it almost seems like trying to decide which room to have it in is counterproductive to the expansion of these programs.
Yeah, I like the phrase table stakes, Mike, because it implies the price of entry, right? It's the cost of doing business for healthcare systems that they want to innovate and remain competitive. And that's the approach that we've adopted in our efforts to build the healthcare system of the future. It's just the new standard of care. In fact, we're in the process of building a new 72-bed inpatient facility that will open about a year from now, and every bed will be wired with Caregility technology. We'll use the technology for a variety of use cases like virtual rounding, remote observation, specialty consults, patient-family communication, even tele-ICU level care. And the funny thing is, it was an easy sell to hospital leadership because they understand the importance of hybrid care and balancing staffing demands. Plus, we'll be integrating it with the patient experience that will include things like streaming services, information about their stay and their care team, educational resources, the ability to order meals, environmental controls like room temperature and lighting. I just think hybrid care is the new standard.
And, you know, one of the things that goes along with that is, you know, the ability to scale. Got an interesting story of one of our customers. They started a telenursing program, and what happened was a couple of nurses that were about to retire because of physical issues and not being able to be on the floor were able to participate in the telenursing program, and thereby they extended the careers of those nurses. They kept these experienced nurses on staff, and they were able to extend those programs. So what does it take to scale? Things like that obviously help, but what does it take to scale hybrid care?
Well, first, Mike, I'll just mention to your anecdote, we've seen a lot of retirees come back into service, and that's great. In fact, one of the people that runs our hospital at home program, Candy, who you saw in the video, has retired twice now, and she's come back twice. So glad to have her. But with regard to, you know, scaling these programs, we seem to like the pilot approach where we start small and prove that the model works, because then scaling is just a matter of resources and it can grow organically. A lot of times it comes down to maximizing scarce resources or extending their experience to the bedside like we do with EICU and telestroke. In some cases, it's about patient preference. We started offering virtual visits during COVID, and we've continued to offer them for patients who prefer the convenience of hybrid care. Of course, cost is almost always going to be a factor in healthcare, but you need to think about it, both the initial investment and the ongoing operational costs. And I would say, ask yourself, can I replace something else by adding this to my portfolio? Because it's very difficult to just continue to add and add without finding an offset or cost saving somewhere else.
Right.
But to do anything at scale, it cannot exist in silos and pockets that are scattered throughout the organization. In fact, a good example is our commitment to building a digital medicine hub. We're taking most of our virtual services and putting them under one roof. And by doing so, not only will it be a showcase for our health system of the future, but we're expecting to find operational synergies by having these virtual care teams collaborate in the same physical space. So teams like EICU, Transfer Center, RVM, RPM, interpreter services, and virtual nursing will all be working alongside each other. So I kind of think of it like mission control, you know, the big room filled with giant screens and 1,000 people that are all tracking the health of the spacecraft to make sure that the astronauts get home safe. That's how I envision our digital hub. We're also investing in a new digital innovation team to support rapid scalability. Digital health, and especially AI, is evolving so quickly that we need to operate at a faster pace to keep up. So I'll be leading a new multidisciplinary team to focus on emerging technologies that support our system initiatives and foster collaboration with our care teams. The whole idea is to identify opportunities, experiment with proofs of concept, fail fast if necessary, iterate, and then deliver a solution or look at alternatives. And in general, I think other considerations to keep in mind with regard to scalability are things like provider capacity, stakeholder engagement, the technology itself, and I would say administrative requirements, because these programs do not run themselves, and they often require a realignment or a reinvestment of resources.
That's so, yeah, it's interesting as we watch customers expand programs. You know, a lot of the challenges aren't necessarily with the technology. It's with the operational workflow. It's with how do you scale the programs? How do you get people to accept change? You know, that's always a big one. So you've done a great job of expanding hybrid care, and it's obvious by some of the things that you've accomplished. Do you have any advice for some of the health systems that are a little behind you guys in getting down that path, and how they can drive these things forward from innovation on hybrid care?
Yeah, a few thoughts on that, Mike. I think it goes without saying that stakeholder engagement is very important. As an IT guy, I'm not going to be able to force a provider to do something they don't want to do. It's generally more successful when somebody approaches us with the idea or the need that they're trying, than I am in trying to sell an idea to somebody who's already overburdened. That said, I believe the stakeholders need to own the service that they provide. And we had a great example of that when we rolled out our RVM program to nursing. Nursing leadership really took ownership of the development of the workflow, the clinical protocols, training and education, while we as IT focused on the technology and vendor management. It was a very collaborative partnership, and at the end of the day, they were fully invested in the program. But every program is a little different. I think there are some common lessons that we've learned over the years. I mentioned stakeholder engagement, addressing privacy and security concerns, effective communication. But there are other less obvious ones, like doing technical and operational dress rehearsals to identify gaps before launching a new service. I think it's important to understand the problem you're trying to solve. You really don't want to deploy technology for the sake of technology. Sometimes we innovate to address needs in other parts of the business, like our hospital at home program. While I mentioned it's great for patients, that was really a means to reduce ED borders at our largest facility. But also make sure you're using technology that's appropriate to the level of care. You don't want to over or under engineer your solution. The quality of hybrid care model should always be considered first. So another thing we focus on is continuous improvement. We use the lean PDSA cycle, which is plan, do, study, and act. So after we implement, we look at whether we achieved what we intended. And if not, we act on making improvements to the overall product or the process. So we say go to the Gemba, and that is go to where the work is being done and observe and ask questions for better understanding of the desired outcome. And lastly, I would say celebrate your wins. Share your accomplishments whenever you can.
Yeah, I think that's great advice. And, something that I want to stress to all who are listening is this cannot be a siloed effort. Bring the right resources to sit around the table, listen to your clinical team, and if you can get the clinical team to drive it, that's even better, because they're going to buy into what's happening. All too often, we have found where one part of the organization has this great idea and they try to start implementing it, and then they hit brick walls because they haven't gotten the buy-in from some of the other parts of the organization. So I think that's a really important aspect of this.
Agreed.
Well, David, thank you very much for joining us today. I really appreciate it. I hope our viewers find value in what you've done and accomplished with UMass. And I'll hand it back to Mackenzie.
Thank you, Mike.
Thank you so much, Mike and David, for a fantastic presentation. We will now dive into our Q&A session. The first question here is, what staffing ratios are you using to support your care models?
David, you want to kick that off?
Sure. Well, not surprisingly, they vary. If I start with our EICU program, we monitor 150 critical care beds around the clock with two intensivists on any given shift, with the aid of a pharmacist at night. For hospital at home, we're right around a 4-to-1 ratio for field nurses and a 30-to-1 for virtual nurses. For our RVM program that we talked about, we maintain a 6-to-1 ratio, but to take advantage of the full 12-patient panel, we assign each observation tech 6 primary patients and 6 backup patients for a total of 12. That way we can ensure eyes on every patient all the time.
Yeah, and that's what we're hearing from other customers too. Those ratios make sense. Although we are hearing them trying to push the telenursing ratios up a little bit higher, maybe as high as 60-to-1,
wow,
70-to-1, something like that. But I think, it's going to be interesting to see, if that's feasible as we move forward. But that's about, that goes back to some of those KPIs that you need to track.
Right.
And I think, failing fast, like you said before, learning what those ratios are. I think on the sitting observation, we're seeing pretty much like an 8-to-1. You said 6-to-1 primarily. Yeah, I think we're seeing that as well.
Thank you both for that response. Moving on to our next question here. What features and integrations have you found to be essential?
Maybe I'll answer that in respect to our hospital at home program. The solution includes a continuous monitoring device for vitals, as well as point of care devices like a glucometer or a smart scale that can be set up based on the patient's condition. The devices run on a cellular data network, so we don't have to depend on home internet, and they feed alerts that might indicate that the patient is at risk. They get on-demand video visits, including translation, in addition to 24/7 emergency access. The patient experience includes daily reminders and surveys for added context like, how are you feeling today? Did you remember to take your meds? Those kinds of things. When we first launched the program, we did not have seamless integration with Epic, and that caused a lot of duplicative work. So we've since implemented tighter Epic integration to prevent that and to simplify the referral and enrollment process.
Yeah, and what we're seeing is, when you talk about at scale, and having something in every room, wall space is so limited. Really some basic stuff like integrating with the IPC systems, the monitors in the rooms, integrating with nurse call systems, so that there's, kind of a centralized notification capability. So a lot of what our customers are looking for are kind of integration with technology that they've already invested in, so that they can expand those programs.
Yep, and I think it all goes back to the patient experience and building the health system in the future.
Yep.
Wonderful. I think we have time for one more question before we wrap up. Do you have plans to leverage AI, and how will you manage regulatory considerations?
Yeah, I figured somebody would have an AI question. There's no doubt that AI is at the top of the hype cycle, and we're definitely exploring it. We've already implemented pockets of it in radiology, ophthalmology, and as part of our DAX Copilot rollout. But we're also seeing the potential for machine learning and predictive analytics, large language models, Gen AI, obviously, and robotic process automation to become really transformational in healthcare. And actually, Mike, can you talk a little bit about your advancements in the computer vision technology as it relates to remote observation?
Sure. Thanks for that, throwing that to me there. Yeah, we're looking at this, and what we've been kind of terming it is responsible AI. In that, we hear a lot of hype about AI. Our customers are hearing a lot, but is it practical in the workflow? Is it adding value? Is it improving the patient experience and outcomes, or the clinician experience? And so we believe that, AI in the hospital room is really going to be addressed by three things: visual analysis, audio, analysis from happening in the room, and ingesting data from the room in some way, shape, or form. And so we've done a couple of things. One is the visual analysis is, the typical, can you determine if the patient is getting out of the bed, got out of the bed, sitting in the chair, or sitting in the bed, are the bed rails up, things that, people sometimes have to physically go in to check, we can do from a visual perspective. The other is contactless vital signs. I think this is going to be really big as we go forward. The ability to take breathing rate and heart rate, and capture that and show trends, I think will be really important for like a telenursing application, because if you could get that trend over time and have the AI that tells you, hey, something's changed in that patient's trend, that provides more information to the caregivers. So our approach is to leverage, whatever inputs we can to give more information, and again, really provide responsible AI.
Well, I'm excited to see where that goes, Mike. And with regard to the governance side of AI, we're still early on in that process, but we're certainly thinking about it. It's no longer about how we use the technology. It's more about how we interact with it. And AI is a profound shift in that human-machine relationship, because it now has the ability to develop an informed opinion. But for now, to your point, Mike, it's about transforming data into timely and actionable information. I don't think AI is going to replace doctors anytime soon, but I do think the ones who embrace it will probably surpass the ones who don't.
And I'm sorry, David, go ahead.
No, please.
I would add, we were just meeting with a customer and they asked me a question and they said, will AI help us reduce the number of nurses? If that's the way you're going into looking at AI, that is the wrong way to look at it. I think right now we have to look at how can we provide more information to the caregivers so that they can, focus their attention and their time in the right areas. I don't think it's at the point now where we're talking about reducing headcount as a result of AI.
We're not there yet, but I will say it's a great time. It's just a great time to be in healthcare, and particularly healthcare IT. People are embracing technology in ways never thought possible, and it's making hybrid care models not only plausible, but also practical. So thank you for letting me share our story, Mike.
Thanks for joining us. And thank you, Beckers, for having us.
Thank you, Mike and David, both for that fantastic presentation. Looks like this is all we have time for today, but I want to thank our featured session sponsor, Caregility. And thank you for joining us at Becker's Hospital Review Digital Health and Telehealth virtual event. Enjoy the rest of your afternoon.